Welcome to everybody. My name is Anaïs Ramirez Sebastián. It's a pleasure for me to give you this lecture. I'm from Universitat Internacional de Catalunya. I'm part of a restorative department of our university, and Dr. Akram told me that I have to give you a short lecture about gospel coverage. Okay, is what we call also indirect restoration. Remember, about this topic, it's very important that the preparation design and a visual protocol has to be very respect. Okay, so very, very important, and we are going to give you some tips to follow and to start with patients immediately. Long time ago, what we were doing is full metallic crown coverage, and that's not bad, because when we have a big tooth with a big destroying structure, and we lose a lot of structure in a tooth, what we do normally is full metallic crown, and it's okay. But we're going to another type of dentistry, that this type of minimally invasive dentistry. Okay, so remember, and we are going to give you these tips to follow minimal invasive preparation. So we're going to have maximal tissue conservation. We're not saying that full metallic crown it's bad for sure, but what we are saying now, what with evidence is saying now, that we have to follow this minimal invasive preparation. And why? Edelhoff, if you read some papers about this author, it's an amazing author, an amazing professional, in a paper published in 2002, explain us why this type of complete crowns are not so good. Because at the end, when we prepare a crown, we are doing invasive preparations. We are removing about 75% of structural removal. So what we want is to maintain structures. So we're going to have these in minimal invasive preparation designs. Okay, we have a lot of classifications about when we have this a tooth with a tooth destroyed. Okay, with a lot of when we miss or when we lose a lot of structure, and normally we find it in root canal treatments tooth. Okay, that it's normal. Roca, Dieci, our university also, Atlas and Grandini published a lot of papers with this classification system for restoration of root fillet teeth. And it's very important to follow these statements. One paper that we love it's the last one published in 2020 by Atlas, Grandini, Martignoni, who gave us a table, a very important table, that if you follow it, I think that you can lose it. You cannot lose it. So, and they explain us as the other classification that we have to restore a tooth following a cavity configuration. And it's very, very nice because they divided premolars and incisors versus molar. And look, if you follow this table, you will find that, for example, glass fiber post, we're not talking about metallic post, glass fiber post, less invasive, exactly. We don't use it till both ridges lost in a premolar or incisor. But if you go to molars, if we have to use a glass fiber post, that's not mandatory. It's not a rule. It's something exceptional, okay? So look, you can restore a premolar with an access cavity, with a class 1 cavity, with composite filling, yes. You can restore a premolar when you lose just one ridge, for example, mesoocclusal, distocclusal, yes, with a composite filling. But look, when you don't have walls, they told you that it's maybe they said to us that the ideal restoration is to go for a crown, to the big to go for a big gospel coverage. It's the same in molars. No, look, in molars, a part of glass fiber post, you can restore even with a big destroying tooth with composite filling, with class 1, class 2, MOD maybe. But MOD, they recommend to you to use a gospel coverage, okay? They don't mention if it's a partial or a total, but they recommend to you to go for a gospel coverage. So that's a very nice table that you have to follow. After that paper, for us, the more maybe newest paper, it's one published for Cardoso, part 1 and part 2. That's a very interesting paper where they create a decision making about gospel coverage. They divide it between vital and non-vital tooth, and they show you, as you can see in this table, in this maybe picture, how they recommend to restore this tooth. And they are taking care about two structural factors and clinical context. That's very nice, because nobody just think about this clinical context. It means occlusal load, it means carrier's risk, it means erosive risk. Nobody before took care about this. For sure, we have to take care about the central cavity depth, buccal and lingual walls, marginal ridge, contact points, enamel cracks, cervical lesions. So take care of that. This is the part 1, and we have also the part 2 that more or less is the same, okay? But it's very interesting if you want to read it. So what we have to do is this type of minimal invasive preparations called indirect restoration. So we want to do gospel coverage. If we are doing in that indirect mode, we have minimization of polymerization stress, we have better control of anatomic form, we have surface finish better, and we can create a good proximal contact points. That's very, very important. What we have, types of preparations. That's a picture just showing you which type of preparations we have. Sound tooth, inlay, onlay, overlay, and crown. That's the 4 types, okay? Let's go to talk one per one. The first one, inlay. This is an indirect restoration also, but it's not a gospel coverage. Remember, we are not touching any cusp. So different configurations. Can be a class 1, can be a mesio-occlusal, disto-occlusal, or can be even MOD, mesio-occlusal distal preparation, okay? But everything indirect. So Lavo is gonna prepare for you this type of preparation and indirect, and you are going to cement after. This is the next one. We have inlay. So now we want to explain you what is an onlay. Onlay is a gospel coverage, but it's a partial gospel coverage. It means that if you maintain just one cusp, you always talk about onlay. It's not overlay, Configurations, a lot of them. Here you can see pictures. So, but what we have is to reduce the cusp that is so destroyed, okay? So we have to reduce the cusp and protect that cusp. If you have 2, 3, 4 cusps, as you prefer, okay? But this is only partial indirect restoration. After, we have also the third one, an overlay. Overlay is a total gospel coverage. It means that we have to protect all the cusp of the tooth. Look, because in all the slides that we present to you, we have also just one type in the third picture that can be something different, like an overlay veneer. Okay, we can prepare this if we have. It's because of aesthetic, because sometimes the smile of the patient is so big. So if you reduce just 2 millimeters, for example, the cusp that we have to protect, sometimes you can see the line. So you can prepare an overlay veneer, what calls von lay, okay? It's an option. And after the last one, the last but not the least of the most it's one preparation that we can do. It's called endocrown. Endocrown. So we describe inlay, onlay, overlay, and now we have endocrown that it's the same that an overlay, but what we want is to just go inside the pulp chamber, just to be sure that we have more adhesive surface. That's all. We can create an endocrown veneer also, but look, it's the same. We protect all the cusp, so it's a total cuspal coverage. But what we want to improve is the adhesion, the surface adhesion. So we are going inside the pulp chamber. For sure, we cannot forget the crown, that it's also a cuspal coverage, but it's not with this minimal invasive preparation. Okay, so we describe inlay, onlay, overlay, and endocrown. To create this type of preparations, what we have is 2 important papers that you have to read. One is from Ferraris, 2017, and the other one is from Marco Veneziani, 2017 also. We're going to explain the same as this paper. It's just to give you indications, just to create this type of preparations, okay, in posterior. Let's see. And we have 5 principles. To create this type of preparations, we have to follow 5 principles. And we're going to start. The first one, it's that the thickness remaining walls has to be more than 2 or 3 millimeters. It means that you have to calibrate the walls, and if that wall measures less than 2 millimeters, you have to protect, okay? If it measures more than 3 millimeters, 3 millimeters, you can maintain it without protection. That is the first principle. The second principle, the bud joint preparation in interproximal areas. We have to create a bud joint in interproximal areas. This is the yellow, what we have in the yellow, what is yellow in the picture, okay? Bud joint, always, very, very important, okay? Third and fourth principles to follow. Interior walls diverging 6-10 grades. It's always the same for a crown, so it's not something new, but you have to follow and you cannot forget it. Something very important, and a lot of you always fails about it, it's occlusal anatomy reduction. We have to protect 2 millimeters, but it not has to be flat, you know? You have to follow the anatomy, because we have fissures, we have all the anatomy, and we have to follow. If our reduction is 2 millimeters, if it's flat, in some points, we're not going to have 2 millimeters. So very, very important. As you can see in the pictures, just following the anatomy. And finally, the last principle and the newest principle that Ferraris and Veneziani is giving to us is this bevel preparation in axial walls. As you can see in the pictures, it's something that you create with a little bit of inclination, okay? But remember, you can see the line of preparation, you can see the finishing line. It's very, very important. You cannot polish this part. It just giving an inclination of your burr a little bit, just to open the enamel, the prisms of enamel, okay? Just to have more adhesion. It's not static. If we want a static, we're going to create a bevel. But what we want here is just adhesion. So they recommend to us to create a bevel preparation in axial walls. So we have these 5 principles to follow to create this type of indirect restorations. Remember the reduction, that it's minimum 2 millimeters. It's not flat. It's following the anatomy as you can see in the picture again. Okay, it's incorrect. The red, what is written in red, it's incorrect. So we have to follow the anatomy. So if you want to reduce 2 millimeters, it cannot be at the same time. Okay. One thing that is important also in the contact points, in the proximal areas, you have to open very well. If not, you will have problems to take impression, digital impression, and to cement your cuspal coverage, your overlay, your onlay, whatever you have. Inclination, for sure, 6-10 grades. It's not new. And remember, the walls has to be more than 1.5, 2 millimeters, 2-3 millimeters. Depends of what paper are you reading, okay? But more or less there is consensus, so 2-3 millimeters. That's pictures, that photos are taken from Veneziani's and Ferrari's papers. So it's what we want. It's we have 3 types of preparations, okay? The picture of the left picture, it's a bad joint preparation, an overlay with a bad joint preparation that it's not bad. What they recommend us is this bevel preparation in axial walls. It's in the picture in the middle. It's an overlay also, and a bevel preparation. And after, in the third picture, you have a shoulder preparation. It's an onlay, it's not an overlay. You see, it's a partial cuspal coverage, but it's a shoulder preparation. It's bad? Not. But what we recommend is to go and follow this bevel preparation for your indirect restorations. Something more to add to these 5 principles that we cannot forget. It's always to have absence of sharp edges. That's very important. Internal rounded areas, also very important. And remember, at the end, what we will have is the presence of surface conductive to adhesion. What we want is enamel and composite because of the build-up. That's very, very important, okay? One thing before to stop is to give you, because we have the principles, we know how to prepare these indirect restorations, but before to create these preparations, before to go with a bar and create this type of preparation, always we have something to do. And in the bite wings, it's what we give you the answer of my questions. What is what we have to do before to go and to give this bevel preparation, these rounded angles, everything? It's to make the marginal elevation, cervical marginal recollocation. It's when you have a gingival margin of a class 2 interproximal cavity and you cannot isolate very well with the rubber dam. You can do surgical crown lengthening for sure, but you can also do the marginal elevation that consists in placing a base of direct resin composite using a metal interproximal matrix to elevate the interproximal underneath indirect bonded restoration. That's very important, and always, I don't think if you have to do it every day, but in our cases, it's always mandatory before to prepare the indirect restoration. Proximal box elevation technique, cervical marginal recollocation, the marginal elevation. We have a lot of papers about the marginal elevation. It's a super topic nowadays. Maybe the paper that it's most read it's Magne from 2012. We have also a review of Zulowski, 2017, Sarfati, Jesse, Bertoldi. We have nice papers. And the paper, the most important paper is from Manya 2012. Okay, that's they explain us how to use a matrix in a matrix technique, and to create this marginal that it's subgingival and to put it in supragingival. You use a matrix like automatrix, autoflamir, whatever you want, and sometimes you place inside this matrix another matrix. But in 2021, Magne published again his paper, okay, but maybe with more pictures and with more, it's just 2 pages, not more. It's everything is pictured and it's nice to read, and I recommend to you. And then they explain the same, how to do a matrix in matrix technique. And I want to show you how to do it in vivo, okay? We have a molar, an upper molar, and we place an automatrix, autoflamir, we fix it, and we realize that we cannot get this margin because we have something there. As we have the defect because of the caries, we can cut a new matrix and just place it inside. And look, maybe you can fix it with Teflon and just start with restoration with your adhesive system, with the resin, everything. Remember, what we want is just to elevate this margin. We don't want anymore because after we can put a matrix, a wedge, something different, or we want to do the preparation with a bar and everything. What we want is just to elevate this margin in mesial and distal. That's all. We don't want anything more, okay? And it's very clear. We have to fix it very well just to avoid saliva, to avoid the bleeding of the sulcus and everything, okay? And everything is explained in this paper from Magne. So sometimes with a simple autoflamir or at automatrix, we can solve it, but sometimes not. Here we change it a little bit, the inclination, and we solve it immediately, okay? After this paper of Magne, 2 maybe important papers published in 2022, 2023 from Gabriela Romano, from Bezer. They explain a little bit this technique if we want to use, which is the bone crest distance, more than 2 millimeters, less than 2 millimeters, just so we can do an isolation with rubber dam. If we have to do crown lengthening, if not, okay? So, but the option or the objective is this interproximal marginal recollocation to have a final restoration. Sometimes we are discussing about if these type of margins, they have toxicity, they may be creating a dental trauma in the gingiva, but Berthold in 2020 that show us that histological and clinical results show that well-polished composite restoration placed in the gingival sulcus and without invading the biological space are very compatible. So we have to use, we can use, it's very important. We have to avoid crown lengthening, surgical crown lengthening. 2023, Marcus Blatt, super author that present us these present and future directions that more or less is the same that Magne present. So we have something like this, a case with a 3.6 molar that we have a big, we lose a lot of structure in distal and mesial because of a composite. We have to clean it and we have to elevate this margin just a little bit, okay? We can modify the wedge with some Teflon, very simple tip that you can use it every day. And after that, you know that you have to protect and create an overlay, a total cuspal protection, okay, following the table from Atlas and Grandini. We make the restoration just to create this composite, this build-up, just ready for the preparation. And this is the preparation ready for the impression, digital impression, and ready for the cementation when we have the indirect restoration in our hands. X-rays to follow, okay, just doing the root canal treatment, marginal, deep marginal elevation. Root canal treatment, this is the bite-wing and periapical before the start the clinical case. This is the final case after doing the deep marginal elevation and cement the indirect restoration, that is a total gospel coverage, okay, an overlay. These pictures that how we did it. Look the line that it's not static, so we don't need it to create here a veneer. So what we can do is just leave it like this. It's not static. Patient is not going to tell you that you have a line. Depends of the smile for sure, but you can do it like this. Always check if your deep marginal elevation is well done with a bite wing. Look, in the initial X-ray, we can see the big caries in 1.7, and the final X-ray after deep marginal elevation, we can see that there is no gap. There are not gaps in between the margins, okay? For example, the same in this 4.6 with a big amalgam emergency. Maybe you can see here a gap, so don't worry. They can leave it like this, and when he came again, you are going to use rubber dam again, so you can change it immediately and just take the impression with the rubber dam isolation. This is, for example, another case with a premolar that is smiling you. And what we want is this margin, this distal margin, just a little bit up and have to convert to supramarginal. This is a bite wing, a periapical, to confirm that you are doing well, that it's very, very important to confirm it. This is, for example, a case, a 2.7. We have also a 2.8 with occlusion and without caries. And in this case, we cannot perform a deep marginal elevation without a crown lengthening. So let's do it. Let's go for the root canal treatment. In the same session, just do the crown lengthening, and in the same session, just go for the deep marginal elevation, the build-up, and preparation of the overlay. In this case, an onlay. As you can see, we maintain some cusp. This is a nice case also from a patient who wants to maintain, who wants to save the tooth. They have two defects, mesial and distal. They have a big lesion in the MV root. So what we have to do first is to make a CBCT, do the root treatment, and be sure that we can save and we can pass we can do the root canal treatment again. And here, Nestor, I'm going to go up exactly. You can see how to prepare this build-up previously to do the preparation of overlay. Okay, so go for an automatrix, an autoflamir, a simple one, okay, and fix it very well with wedges. And after, be sure with the microscope, as you can see, that is very sealed. In the right side, you can see the X-ray, the final X-ray of the root canal retreatment. And after, go for it. This is the build-up, okay? X-rays and final one, okay? This is another patient, Myler, okay? It's a premolar. And we have to retreat again and place an overlay, a big protection, okay? And you can see here how to remove everything inside the root is what we have here with the rubber dam isolation. And now is starting to create the build-up to do an overlay. Remember, if we prepare this tooth like a crown, we're going to just have a root. So that's very important to maintain all the ferrule effect and all the structure that we have to avoid more destruction and to be less invasive. That's very, very important, okay? This is the case, and after making the build up, you have it like this, and after you prepare it like this. You have the periapical, the bite wing confirm you that your demarginalization is done. And let's go for the cementation. Cementation, it's not our topic today, it's not our lecture, but it's just to see a little bit video how to cement this crown. We protect it, we sandblast the tooth because we have resin, okay? We just place orthophosphoric acid to clean the abrasion particles, and to prepare it we have some enamel, just silane before the adhesive system and after the adhesive system. And look here, we prepare, we just maintain it isolated, and we are going to cement the overlay, just pressure, okay, and it is the final result. This is the final X-ray, bite wing, and periapical. Very, very important. Recommended burrs. These type of bars are very, very important because it's a flat part that it's super nice to create that bad joint preparation in the interproximal areas. So follow these bars. Just check with your what we have, and that's very nice to follow with this. And here, finally, I want to show you just a video how to follow and how to do an overlap preparation. Initially, just remove it, everything. We're going to do the root canal treatment, and let's go for the build up. As you can see here, she's Noemi. She had a crack, so she was with pulpitis, irreversible. So look, okay, this is the build up, just following the principles after what we need. Just a build up, not too much, just to confirm that you are going up a little bit up, okay. This is our result. And after, look, with the burrs that we recommend to you, let's go to create this reduction. Just take care in the interproximal areas, go with a little one, exactly like you can see in the video. Protect very well the other tooth, okay, the Janssen tooth. Super. I love this burr just because it's rounded and it's nice. Just polish a little bit more, maybe with a disc, a soft like disc, and maybe with a polish band, okay, that's nice also. Just to confirm that your contact point is free, it's without any, that's very, very important. And you can just take impressions. This is the final results, and let's go to cement as I presented before. Abrasion particles, orthophosphoric acid to clean it, water, silane if you have composite resin, and your adhesive system. You protect the light, the microscope, and let's go for the cementation. We're doing cementation, and just be sure with the floss that you have contact point. don't stress, you have enough time, okay? Because it's a photo cementation. Just exactly pressure, floss again. Good coordination with your auxiliary. And this is the result. Polymerization, 1 minute per wall. And this is the nice result for the case. Super. Thanks for this first part about indirect restorations. If you have some questions, please ask me in this email.